Welcome, everyone. My name is Tanya LaRue, and I am so honored to be tonight's moderator. I'm education lead with Caregiver-Centered Care, where I've worked with our team to co-design education to equip health and social care providers to recognize, partner with, and support caregivers to sustain their care and maintain their own well-being. And we recently received new funding to co-design an Alberta caregiver strategy and action plan with multiple partner collaborators from across Alberta to fortify partnerships and strengthen caregiver recognition, engagement, and integrated supports for caregivers. And I'm looking forward to engaging with and learning alongside and from all of you as we partner a path forward. And it's with great humility and responsibility that I pay respect to the Indigenous peoples of all the lands from which we join this virtual webinar. I join you from Treaty 6 territory and District 12 within the North Saskatchewan River territory of the Métis Nation within Alberta. And these territories are ancestral lands, home, or gathering place for Nehewa, Niitsitapi, Nakota Sioux, Métis, Haudenosaunee, Anishinaabe, Dene, Inuit, and many more Indigenous peoples. As a white settler on these lands, I am grateful for the footsteps, histories, and cultures that have marked these lands for centuries and continue to shape our communities today. Caregiving is valued within Indigenous cultures and it spills into other relations, informing collective wisdom. And today I worked with my parents to plant our family garden. And as we worked with the dirt, water, and seeds, Indigenous stories about the three sisters, corn, beans, and squash, that have been graciously shared with me by Indigenous women were called forward in me, reminding me about shared responsibility and partnership. When together, these sisters work in synergy, sharing their unique gifts, networks, and caregiving to create collective impact that yields more food than if you grew each of the sisters alone. And as we consider what is needed to support caregiver thriving, I'm reminded of our garden, knowing there are many possibilities, especially when we come together. So, in this season of spring and growth, during tonight's discussion, may we dedicate ourselves to building circles of care, collaboration, and partnership. And may we weave our individual and collective gifts and wisdom to engage, contemplate, and enact the possibilities that lay ahead for caregivers to thrive. To begin engaging with our collective wisdom, in the chat, let us know your perspective. I'm going to type a sentence here and just add it, but the sentence is caregiver thriving is. So in the chat, I would love to hear your responses. Caregiver thriving is. And through the polls, let us know your roles and your locations. So I'm just going to launch those polls for us. And as you complete the sentence, caregiver thriving is, and the polls, I just want to let you know that along with the link to the recording, we will share a digital swag bag, which includes key information, messages, and resources discussed today, along with contact information of some of our speakers. And we will have a Q&A near the end of our time together following our panel discussion, which follows our presentation. And so throughout the webinar, please type your questions into the Q&A box so they do not become missed within the chat. If you actually put it in the chat, we have some chat moderators who are going to move it to the Q&A for me. So I am seeing there's still people answering the polls. There's still people answering the chat. So I'm going to keep going and I'll come back to it. And so I'm just going to say thank you all for joining us. I see we have a variety of roles joining us. I see that we've got people from across Alberta as well as another province. And I'd like to express my sincere gratitude and awe for the caregivers and care partners who join us today. You are the shadow workforce of our society and the backbone of our healthcare system. In fact, caregivers in Alberta contribute 647 million hours of caring per year, the equivalent of $11 billion annually. And when we broaden that lens to caregivers nationally, contributions are equated to $97.1 billion, which is 3 times expenditures on home, community, and long-term care. So supporting caregiver thriving is key. And I can see here caregiver thriving is not yet attainable. Yes, this is why we need to support these diverse needs. It's a wonderful dream. It's having support. It's love. And I continue to put in your comments there. I'm going to close the poll for us here and just share the results. So again, we've got a mixture of people. We've got a lot of caregivers and care partners with us. We've got healthcare providers, community or social care providers, educator and researcher, and a couple of students with us. So thank you for letting us know who's joining us. And I think as we consider supporting caregiver thriving, we can see that caregiving touches all aspects of caregivers' lives. Caregiving is rewarding and it's also challenging. The number of available caregivers is shrinking and care needs are becoming more complex, resulting in more intense and demanding caregiving. And so it's no surprise that we're seeing increasing distress, declining well-being, and increasing burnout among caregivers. So the urgency of ensuring caregivers have the resources they need to support their thriving is clear. And as I look back to the chat and these themes of, I'm not sure it's possible, it's not there yet, it's a dream, I see a common root to caregiver thriving as supporting caregivers' needs. And so without further ado, I'd like to introduce our guest speaker, Dr. Donna Wilson, who will present on our research, A Day in the Life of Family Caregivers. Donna Wilson is a registered nurse who has just retired after 35 years from a full-time tenured position as a professor in the Faculty of Nursing at the University of Alberta. And Donna has worked as a staff nurse, a nursing supervisor, senior hospital administrator, media commentator, educator, researcher, and professor in Alberta, British Columbia, New Zealand, and Texas, as well as unpaid positions in Ireland, Belgium, and England. She has over 400 published peer-reviewed communications and is frequently consulted for expert commentary on aging, end-of-life care, bereavement, health policy, healthcare services, and health system trends and issues. So Donna, I'm going to hand it over to you.
Well, thanks so much. I'd love to talk about the study that I've just finished. But before I get into that, I just want to say thanks to the organizers of this and all the many groups that do so much. And to the people who are attending today who are probably a caregiver or have been a caregiver. And to be honest with you, after being a hospital nurse and all the rest of it, it was when I became a family caregiver, I realized how little I knew. Looking after somebody at home and trying to get them help and all the rest of it. Yeah. So anyway, I've just finished a 4-part study, and believe it or not, it was funded by the current government that we have. And we're very aware that we have population aging, and we maybe need to start to do something to help older people, age in place and also help family caregivers. So it was really heartening to get the funding. Now, I've really been interested in population aging for some time, which is a wonderful thing. I mean, more and more people are living well into their 80s and 90s, even 100-year-old. In fact, in Alberta now, 15% of people are 65 and above, which is just, it would have been unheard of 20 years ago. And that number will go up. And more people are reaching the age of 85. Now, 85 is quite a marker though, because very few 85-year-olds still drive. Although my aunt, who's 104 and lives in North Edmonton, is still driving and very much telling you that nobody's going to take her license away, what have you. So 85, though, many people, when they hit 85, aren't driving anymore, and they tend to not be quite as strong. And that's an age when typically they begin to look to family members for a bit of help. And family members typically really step up. Now, I don't know if you'd be surprised to know, but in Alberta right now, we have 76,000 people who are age 85 and over. 76,000 people. And I'm putting out some numbers here. By the way, we have 78,000 people who are almost 85. And would you be surprised to know that we only have less than 16,000 nursing homes? So clearly, We don't have, we haven't built lots of nursing homes to put older people in. And in fact, we've only got 8,600 hospital beds. So they're not even in hospital. And we only have 71,000 people who are getting home care through AHS. So that really emphasizes families are probably doing a lot. And so our study, we asked for volunteers around the province, and we got funding for to follow 150 people, where we interviewed them once a week for 6 months. And we wanted to know, what did you do over the past week to help your family member? And this had to be an older family member. Half of them were 85 and above, and the other half were pretty close to 85. So what did you do in the past week? Did you get any help as you were helping, as you were supporting your family member? And what help really did you need and that you didn't get? So it was a pretty simple interview. Once a week, we had nursing students who had their people that they regularly phoned, and they developed nice relationship, really talked a lot. Now, these were very typical family caregivers. A few were male, most were female. They ranged in age from 18 to 87, but of course, most of them were the middle-aged women looking after mom or dad. Some older people looking after their spouse. Some of them were rich, very few. Some were poor. Many were kind of in the middle there. About 50% were working and about 50% weren't. And so really a nice mix of people, and they lived anywhere in the province. So we had rural, urban, we had Calgary, Edmonton, we had them living everywhere. So we could kind of look at, were things different around the province? Well, through those interviews, we identified 11 needs. So this is what family caregivers realized once they started caring for a family member. And as time went on, usually when the needs got greater, number one, they needed information. They realized, oh my goodness, how do I apply for that? Can I apply for that? Can I get help with that? Where do I go for this? Where do I go for that? They had an information need. The second one was emotional support. If you can imagine, and I'm sure many of you can, looking after someone who is a parent or a spouse who is strong and capable, and now perhaps is really needing a great deal of help. And in fact, you can see that perhaps the end is coming, and sometimes quite quickly. Something else that they needed help with was to look after the house, the home, or the apartment. 50% of these family caregivers lived with the person they were helping. 50%, though, had an hour's drive or half an hour's drive or a 20-minute walk. So in fact, 50% of people were looking after two homes, their own home and the home of perhaps their parents, even the farm at times. So it was to help them with the activities of daily living that involve, driving, muscles lifting, that keeping the house clean and what. The fourth one, though, was they needed help with the basic activities of daily living, the bathing, the dressing, the walking, getting in and out of the wheelchair, what have you. They, if you could imagine not living with someone and realizing that they need help and there's nobody there to help them get into a wheelchair, go to the bathroom, what have you, you can imagine that they need help, that they need some help with that. Respite was the fifth one. They needed a break every now and again, a complete break. And many of the family caregivers we talked to said that they had weddings and funerals and everything else that they could not go to because there was nobody that could come in and look after their mom or dad or spouse or whoever it was. They also, the sixth one that they needed some help with was to have some encouragement and support to look after themselves. Many of them recognized that they were burning out. They were getting tired. They knew that this wasn't going to end. It was going to continue on for months or weeks or what have you. And they needed some encouragement to look after themselves. The seventh need they had was some help with transportation. And many of them talked about getting someone who could barely walk or couldn't walk into a vehicle to drive them, sometimes half an hour, sometimes 6 hours to see a physician or see the dentist or go to the bank or what have you. Very difficult transportation issues came up. Other thing was financial help. Some of them talked about how expensive it was to buy attends, to buy insure, to buy all sorts of things that weren't supplied by anyone. Um, the next two had to deal with anticipatory grief. Many of them recognized that the end was coming. And it's very difficult to be upbeat and happy and positive and everything, when at the same time you realize that mom is really deteriorating. A month ago, she was much better. I can imagine in a month or two that she won't be with us any longer. So they needed some help with managing that grief. But they also needed help with managing the grief of the care recipient. Many of the care recipients were right out open and said, I won't be here in a month. And, or some were completely the opposite. Nope, I don't need any help whatsoever. No, I won't let the home care nurse that you've arranged, I won't let them in because I've just refused to need help. So but this is all anticipatory grieving of the care recipient. And last but not least is when the caregiving ended, what a huge change that was. Not only was there grief over the loss of the person that they had cared for months and years often, but suddenly, they had put so much time and energy into it. That had become their life for many of them, and it was a huge switch for them. So those were the 11 needs that they had. And we asked them, well, what kind of help do you get? And we found out that some of them were lucky enough to have an adult day program where the care recipient was picked up or where they could drive them and they would go there for a full 1 day or 2 days a week. And these were wonderful because the person could get out of the house and socialize and have some meals. And sometimes the bankers and the hairdressers and whatever came to these adult day programs. But it also was really what gave the caregiver a break. The second one that very few were lucky enough to say that they had was a respite service where they could really get away from the house for a few hours or days. Oftentimes, if it was a local nursing home, would say, we'll keep one bed open and you can book it in so that you can get a week off or something like that. Transportation, some of them were really lucky that there was a community van that maybe the county or the town or a church group or a seniors group provided, and they could book that and use it. Some of them were also lucky enough to have some help with cleaning the house, either, perhaps their own house if they're living together with a care recipient, or cleaning the house of the second house where the care recipient was living. And last but not least, about a quarter of them, this was the best scenario of all, about a quarter of them got some personal care for the person who needed help. In other words, the home care nurse came in and bathed them and dressed them. Typically, though, it was only once or twice a week. So very much family caregivers doing a whole lot of this kind of on their own. Now, when part of the study that we did was we found people and companies that were providing these 5 services, and we interviewed them. Most of them were really small organizations that would get a 1-year or 2-year government grant. So they could provide the services, usually only in their own little community. And they could provide them though at a co-pay. So you'd have to pay $5 an hour to get someone to come in and clean your mom's home or your that kind of thing. And in fact, the big issue with that was the fact that these were only 1 or 2-year government grants. And then you'd have to reapply for the grant. And many of them didn't get it renewed. And so we actually talked to some seniors groups where they had to phone people to say, I'm really sorry, but next week, you're not going to have somebody to come and clean your house, at $5 an hour, the subsidized rate. So really, quite amazing when you think that there's a patchwork of really come and go services. And in fact, you'd have one town which had maybe all the services, or many of the services, and the next town would have none or one. So there was no consistency, or even within the same city, depending on where you lived in the city, would be whether you'd get home care or not. So the last part of this study was we looked at who's in hospital in Canada, and we got all the hospital data for 1 year in Canada. And would you be surprised to know that only 1 in 3 of all the people that are admitted to hospital are age 65 and above? In fact, the older you get, the less likely you will ever be in hospital. Kids between the age of 0 and 5 were the most commonly admitted to hospital. When an older person came in, it was really interesting to find that very seldom did they have surgery. Very seldom did they go to the intensive care unit. Really, by and large, they came in for nursing care. And of course, basic nursing care, which could be done elsewhere. Another thing, too, that we looked at when we had this hospital data, we looked at who stayed in until they passed away in hospital. And in fact, it was only 91,000 people in a whole year passed away in a hospital in Canada, which is 42% of all of the deaths that year. So once again, that tells us that most deaths are not in that end of life care, not taking place in hospitals. They're probably, taking place, they're taking place at home with family caregivers, maybe getting a wee little bit of help, or perhaps they're passing away in a nursing home. And in fact, when a person did come into hospital and stayed until they passed away, they stayed for an average of 16 and a half days. Now, some of you might be waiting to get into a hospital for surgery or what have you. Well, we have a tremendous opportunity, if there was more hospices or home care, to move some of these people home and out of these busy, noisy places. Most people say that they don't want to spend their last days there. So in conclusion, it's a wonderful study. I can't thank the people enough who gave us such good information. But again, there were 11 needs amongst family caregivers who provided care for community-based older family members. 5 services would really help all of them. Unfortunately, there was such a patchwork of services. And again, you might have it organized and find out it's been canceled. And then you either do without or you pay privately out of pocket. The hospital use data pointed out that less than 14% of old people are in hospital, at least in a year. Unbelievable. So again, all of this points out how much family caregivers are doing, but how little support that we really have for them. And we need consistent funding. It shouldn't matter where you live, or, whether you're rich or poor, or, whether you really argue or not. There should be an equal services across Alberta. And certainly more funding, so we could have more people staying out of hospitals, staying out of emergency departments, staying out of hospitals. So I'll end there, and
Thank
thank you
you.
very much.
Thank you, Donna. And as I hear about this too, I think what strikes me, and as we think about our topic of supporting caregivers to thrive, how much is placed onto caregivers. And it's been highlighted in the chat, and it's caregivers of people of all ages too. Your study was with older adults, but I think there are some needs identified that definitely span across the spectrum. And so for anyone that has questions for Donna, we will come back to her in the Q&A, but I do want to introduce our next speaker here. Debbie Edwards is part of our panel, and Debbie is a retired social worker who lives in Fort Saskatchewan as a caregiver for multiple people with varying needs. In addition to providing care and support for an aging parent struggling with dementia, she shares custody of her 9-year-old granddaughter with cerebral palsy and has 2 dependent adult children. Her daughter, age 30, who lives independently and is successfully co-parenting her daughter with support from Debbie, and her 27-year-old son, who has autism and acquired brain injury with complex needs, who lives at home and requires 24/7 care. She joins us to share about some of her experiences and offer insights about what is needed to partner a path forward and support caregivers' health and well-being throughout the caregiving journey. So Debbie, we'll also come back to you in the as we open up our panel, but I want to hear from you. And I'm sure you've got more than 5 minutes to share, but I want to hear from you. What supports have helped you thrive, and what further supports do you need to help you thrive? Because I think that idea of supporting you to thrive might be a myth right now with all the multiple people that you are supporting.
Yeah. So first I want to thank the people who organized this and the panel, the members of like I feel honored to be asked to be a part of this because I mean the phenomenal work that you guys have done on this project and it's an honor to be asked to join you because lately I have not been feeling so positive about my caregiving journey, and I'm really appreciate the opportunity to reframe that this has given me, to reframe to how are you what supports a caregiver to thrive versus oh my gosh my life is a mess because the fact is I'm not thriving, the fact is I'm struggling, the fact is I am feeling like my trying to keep my head above water, trying to manage everyone's needs that I am responsible for. I am legally responsible for the medical care for my 9-year-old grandchild who has cerebral palsy. She has epilepsy, scoliosis, and a rare genetic chromosome disorder. She was tube fed when she was born and has feeding and swallowing issues and uses a wheelchair part-time. She is not yet fully potty trained and at almost 10 years old. And so she leaks through her, like she often pees the bed and leaks through her diapers, and the amount of laundry that creates is enormous. She has seizures that are not controlled and will miss a lot of school because of that, because she just then sleeps through the whole day. And my daughter, who is her mom, also has a cognitive disability. So I support her in her parenting journey through that, and help her to problem solve and navigate those waters with conflict resolution and advocacy and support for her. We do have a contract with Families for Children with Disabilities for her, which provides us some support for housekeeping, clothing and footwear, mileage to medical appointments, and some respite care. However, for her, it's been a real challenge because we live rural, we don't live in the city, to find, recruit, and retain those respite care providers. When we lost our last respite care provider, we've gone through a couple that haven't been a great fit, and largely haven't had any respite care for her at all. So it's been myself and my adult daughter kind of doing primary care for her. She has an upcoming sedated, like just in the month of June, she has an upcoming sedated MRI. She's on a wait list for dental surgery. She's going to have an IPP meeting with the school because she is in a specialized program. She has an IQ, a low IQ, a disability. She will be a dependent adult when she is 18. And so then we enrolled her in a special needs summer camp. So we've got to do the forms for that, do the physical that's required for that, get her to the pediatrician. And all of that is just in the month of June, just for her. Driving into the city, transportation, that's all on me because my daughter doesn't drive. So and then my daughter who lives on her own and requires some assistance with problem solving, conflict resolution skills, her own mental health, her own anxiety, coping skills. I provide that support to her because her IQ was just shy, which her IQ was 5 points too high to qualify for any supports through persons with developmental delays. And so she gets no support whatsoever. She relies on me, is entirely reliant on me for that level of support. So, and then I have my son who came to me about 18 months ago from Saskatchewan. He has an acquired brain injury and an IQ of 71 and doesn't qualify for PDD supports. He is on, both my kids are on AISH. However, we weren't able to get any support in place for him as far as staffing until about March of this year. so we went without any support for him for almost 18 months. We now have been grateful and lucky to obtain some funding for him through self-managed care, through continuing care home care, to get some hours, some funding in place for him to be able to have some staffing for him to do some ADLs and to work on hygiene with him, personal hygiene, some supervision, because he is very high needs and has very low impulse control, and injures himself frequently. Do some light housekeeping, help him make his bed, help him clean his room, help him with some recreation, engage in some exercise, go run some errands, just get out of the house, go get his haircut without his mom. And he really enjoys that. And that gives me just a little bit of a break so I can do other things. But he, in the month of June, has physiotherapy, he's got blood work, he's got medical care needs that are upcoming, and psychiatry appointments that I drive him into the city for as well. And then I have my dad, who is in his mid-70s and struggling with early dementia, who he still makes his own decisions and is still responsible for his own decisions, but he had shingles in his eye in last month, and it worsened significantly. And his eye, he almost lost the use of his eye, and so he had to go to the eye doctor every 3 days. I'm the one that had to drive him. He was very resistant to receiving my support, and we were providing him with his meals every day for basically 2 weeks. I managed to convince him to accept some home care support very briefly, and he goes for a cognitive assessment next month, in June as well. So he has 2 medical appointments that I'm going to be taking him to, and he has had a bunch of medical appointments this month. So I'm just feeling like I am tapped out and struggling with my own mental health and my own struggles, just being able to support my family members and being able to provide the level of care that they need. And so in order to be successful, I think that, for me, primarily access to psychological services, access to through that I've been able to access through my workplace has been really supportive. It's been my primary source of support, and the respite care and that I've been able to receive, and some level of case management that I've been able to receive. Even though I'm a retired social worker and I have these skills, I haven't been able to utilize them because my coping skills are really low, because I'm struggling with my own mental health. And so I think that for me, those are the 3 key areas that would really support, that would really make me feel like thriving is access to psychological support, access to resources like social work, like some case management, and access to more information about, like, why is the information so difficult to find about what supports are out there and where to access them to get the respite care and the supports that you need.
Thank you. Yeah, thank you so much, Debbie. Sorry, I left you for a while. I got kicked off of Zoom, and we're going to come back to you, but I think it's so important that you shared your story, because I think it brings to life the complexity of caregiving, and that oftentimes you're not alone. You are a multiple person caregiver, and I think there's a lot in our audience today who also are. And so thank you for sharing your experience. And I think it's a nice segue to the rest of our panel to really discuss about partnering a path forward. How do we link these things? How do we create integrated care? And how do we offer all of this nest and network of support that caregivers need? So today, joining Debbie will be Tracy Hayward, Arlene Hune, Beth Mansell, and Daryl Gregory. And so Tracy Hayward has been a registered nurse for 28 years. The majority of the time was frontline with pediatric and neonatal critical care. And 5 years ago, Tracy moved to patient safety, first at Alberta Health Services and then at Covenant Health in Alberta 2 years ago. Her role now involves investigating clinical adverse events, as well as educating and supporting leadership at all levels about best practices for event review and disclosure of harm. Arlene Hune works for the Alzheimer's Society of Alberta and Northwest Territories and has been with the Society for just over 22 years. Arlene is the manager of client services and works with 18 navigators who provide direct support to the families we work with. Arlene is passionate about supporting people live with dementia and their care partners to live well, but recognizes that without the proper support, as we've heard from Debbie, in place, it's difficult to do this. And so in her time at the Society has worked directly with thousands of people, thousands of care partners, has facilitated hundreds of support groups, information sessions, and education sessions. And Arlene is looking forward to hearing the voices of care partners at this session. Beth Mansell is currently the Provincial Social Prescribing Project Manager with Healthy Aging Alberta. Previously, she worked for 5 years as a Strategic Project and Operations Manager at Sage Seniors Association Edmonton. And Beth has a Master's of Public Health with a focus on health policy and management from the University of Alberta. Beth has worked closely with the Canadian Institute for Social Prescribing since its inception and has participated in many working groups to develop and grow social prescribing initiatives across Canada. Daryl Gregory has over 25 years of nonprofit leadership experience as an innovator, strategic thinker, and change agent, and he joined Caregivers Alberta as executive director in 2022. Prior to that, Daryl was a director with MS Canada for 15 years in Edmonton and Calgary. He is a community builder with demonstrated experience in bringing stakeholders together towards a shared vision. He leads a team of exceptional professionals dedicated to supporting caregivers today and creating an ecosystem that ensures caregivers are adequately supported in the future. So we know that caregivers, the people they care for, their contexts, their care trajectories are diverse, and caregivers need person-centered, integrated health and social care that recognizes, partners with them, and supports them. And so let's talk to our panelists, starting with Tracy. What does good partnership that supports caregiver, care partner thriving look like, feel like, and do? And can you share some examples in 5 minutes or less? And I'll tag you in the chat.
Good to keep me on track for time. You know, I've been mulling over this question, and when I first started doing this caregiver education, I had a completely different idea of how our partnerships work. Because at Covenant Health, we really try and engage with the people we serve, and that includes our patients, our residents, but also their caregivers, their families, and also as well as our staff and our physicians. And we are realizing that, you know, over the last few years, between the changes in our society because of the pandemic and how strained our healthcare system is, everybody, the patients, the caregivers, the staff, everybody is feeling this moral distress. Nobody's giving the care that they want to be able to give because they don't know how to find the resources to get that care. And caregiver-centered care is a way for our staff and physicians to advocate for the patients, the residents, the families, and the caregivers, keeping in mind that our caregivers are not always family members. It helps keep our the participants engaged in the healthcare system and taking care of their own needs with our support, which always improves their outcomes. We have been trying to partner with our caregivers in an organizational level. So we have patient partners, is what we call our community members, who have experience as patients, family members, caregivers, who give us their invaluable time and volunteer with us to let us know at an organizational level where we need to go next. So we have patient partners on our quality councils. We have them on advisory council who meets regularly to discuss and provide insight on our organizational changes. So for example, any new program or policy runs through that advisory council to make sure we have considered their viewpoints. We have, anytime we're doing a formal clinical adverse event, we look to make sure that on our our analysis team, that we have somebody with a caregiver or patient focus to say, have we forgotten something here? Are we as leadership and organization thinking that things are happening, but actually it's not what you see on the front line when you're coming in with your loved ones? We've started a pilot program called Healing Conversations, where we are encouraging conversations between our providers and patients and caregivers after a serious clinical adverse event. And we have 2 partners on that program. as we set it up, as we try and figure out how we're going to move forward. And they have educated me greatly on the impact of healthcare provision on the caregiver as well as the patient. So we were considering how would a medical error affect our patients, but we hadn't really considered how much does it affect that caregiver who is going to have to go home with the impact, with the changes and the fear of having had something bad happen in hospital. So at every opportunity, we're trying to engage with our staff and our leaders at different types of forums to talk about, family-centered care, but also caregiver-centered care being different and how much it will help in the long run when our staff are feeling burnt out and they're feeling stressed and they feel like they're not giving the care they want, how to involve the family and caregivers appropriately so that we're not forcing them to take on things that they can't take on right now, but also to give them the ability to say what they do and don't want. I do feel like I can take care of this dressing change today, but you know what? Next time I don't want to do it, or the opposite. Like, what do they need? A constant conversation with our caregivers and bringing them onto that team. So our caregivers in the hospital will be our nurses, physicians, and the families and caregivers with our patients. But we hear these stories, and what I see in the chat box tells me that we're not there. So what we're thinking, we're hearing from the organizational level, we're feeling like, yeah, we've got this caregiver education that was created. We have that out there. We're encouraging our staff and our physicians. We have policies, we have procedures, but then you hear that this is not happening. So we need to know, as your partners, when did things go wrong and what do you need from us? And that's my view.
Yeah, thank you so much, Tracy. And now I'd like to hand it off to Arlene. Again, same question. What does good partnership that supports caregiver, care partner thriving look like, feel like, and do for you? And can you share some examples of how you're working to partner that pathway forward?
Yes, thanks, Tanya and everybody. So I took a slightly different approach when looking at partnerships. And I think the biggest thing we want to share, and I'm sure some of the following organizations will say the same, we know that this is just a small piece of the pie for helping you thrive. So when I answer the question, what do good partnerships look like to help care partners? I really want to look at it and use examples of some of our programs at the Alzheimer's Society. So we have a program called First Link, and First Link is a direct referral system that connects individuals living with dementia and their care partners to a community of learning, services, and support. We partner with healthcare and community professionals, and the referrals come from a variety of different sources, and that includes geriatricians, family physicians, home care, family community support services, or FCSS, lodge staff, and many other places do we get referrals from. Some of the goals of the program are to empower care partners to develop self-competency and resiliency, also to reduce the overall incident and intensity of crisis situations. These direct referrals help ensure care partners will be linked to us, which will help care partners thrive. The Alzheimer's Society also offers support groups for care partners at many different locations, times, and formats throughout the province. We partner with community organizations to host our groups, and we also partner with people living in the community who volunteer to facilitate the groups. We provide the training, and many of our volunteers have been care partners at one point or the other. Support groups offer a safe space for care partners to share what is and isn't working for them, gain other ideas from people in similar situations, and to connect with each other. Being connected can help care partners thrive. And watching the chat quickly as people have been talking, I see that somebody else had mentioned support groups. In our education program called Seeds of Hope, we partner with many different professionals, including physicians, social workers, speech language therapists, psychologists, care partners. Yes, we believe you are a professional as well, and many other professionals to share information with care partners to help them learn and grow in their role as a care partner. Being prepared and feeling knowledgeable will help care partners thrive. We also have a program called Minds in Motion, where both the person living with dementia and their care partner can attend a program together to help with both their physical and mental health. And it is a chance to have fun. We provide, we partner with community organizations where they offer the program and we provide the training. Assisting care partners to take care of their physical and mental health will help them thrive. Mostly we partner with families, care partners, people who need support and assistance with navigating our health system, and sometimes just a friendly voice at the other end of the phone. We offer care partners an organization they can partner with throughout their full experience of dementia. Care partners come to us often at the diagnosis, and we stay with them until and after the person they are caring for dies. We know this helps a care partner thrive. Care partners are not charged for attendance in our programs or to receive our services. Donna spoke about that, how financial concerns, and again, I've seen that throughout the chat as well. I was supporting a care partner today, and she insisted that I say in my presentation that hugs are free at our organization, but only if you want them. She took 2 today. We have a care partner on our board, and other board members have also been a carer in the past. Now, a really important question of the main question was, what should good partnership feel like? As in any partnership, there has to be trust, communication, shared vision, respect, and values that are aligned. When partnering with care partners, it should feel like care partners are able to breathe. It should feel they are supported and connected. It should feel like people care about them too, not just the person they are caring for. It should feel they are part of the team. It should feel like their voice and opinions matter. It should feel good to be a care partner and not be exhausted all the time. And I think many of us will agree that we are still a ways away from all of these feelings, but hopefully working together will push us in that direction. Thanks,
Thank
Ben.
you. Thank you so much, Arlene. And again, we'll come back to this and kind of put it all together, but I do want to pass the mic to Beth. Beth, again, what does good partnership look like, feel like, and do? And can you share examples of the work that your organization is working on?
Yeah, absolutely. I think when I was reflecting on this question, I was thinking that like good partnerships are really required in multiple different levels to really make sure that we're supporting family caregivers to thrive throughout the system. And so the work that we do, social prescribing, I could probably talk about that for much longer than 5 minutes, but I'll try and give a really brief overview of what social prescribing means for the folks in attendance that might not know what that is. And so social prescribing is really a better referral pathway between healthcare providers and community-based supports and services. So we know that those community-based supports and services are often the providers of those non-medical needs. And so by making that really clean referral from healthcare to what we call a link worker, it's also other terms for that, like system navigators. I see someone mention that in the chat here. Are there any trained system navigators here in Edmonton? Yes, there are. Not enough, but there are some. So that link worker then meets with the individual, and it's really a co-creative process where they develop a care plan and get connected to different programs and supports and services that really meet their needs. And so in the case of a care partner or caregiver, they would be the person meeting with that link worker, and that link worker would be making sure that they're getting connected to supports and resources that are meaningful to them. And so if you're thinking about it this way, that in itself requires a really good partnership with a community-based organization like Caregivers Alberta, like other local senior centers across the province. And if we take it back to that healthcare side of things, that healthcare provider really needs to have a good understanding of those kind of social determinants of health, as we would call them, and the social determinant of health needs of that caregiver. And so through our work, we're hoping that we can be promoting this more with healthcare providers across the province. Our work is limited right now to 10 different communities across Alberta. So we're working in Edmonton, Calgary, Lethbridge, and then 7 more rural communities as well throughout the province. And so what we're hoping is that healthcare providers are able to better kind of identify those non-medical needs that caregivers have, that would prompt that social prescription. So that could be through asking questions like, how often are you seeing friends and family? Are you having challenges getting from place to place? Do you need support accessing any social services? And are you able to access healthy foods that you like? So those types of questions that could be prompted from that healthcare professional. And if the individual is responding that yes, they do need support with some of those pieces, they make that one simple referral to a link worker who is within a community-based organization. And then that link worker takes on that kind of coordination role, right? They're the expert, they work in community, they know these resources and supports better than a family doctor or a nurse would know them. And so it's really intended to kind of put that power back into those community-based programs and services. And so once that link worker starts meeting with the individual, that's another new partnership that develops and needs to be a really strong partnership. The caregiver should actively be participating in developing that plan with the link worker. It's really something that should be considering their goals, what their strengths are, and what they really want to look at. I think that link worker role can also play some of that kind of advocacy role for the caregiver as well. I saw a comment in the chat earlier that caregivers are more burnt out from the advocacy and fighting with the system than the actual caregiving itself. So, link workers are they're kind of experts in navigating that system, right? They've maybe got 4 or 5 other people that are currently going through the same thing, and they know those routes to take and which buttons to push. And so I think they can really support caregivers in that way as well. I'll share a story. It's not my own story, so the details might not be 100% correct. But I was chatting with one of our partners at Caregivers Alberta a few weeks ago, and so Caregivers Alberta has a social prescribing program. They have a community connector that works there. And they were meeting with a caregiver that was very overwhelmed, felt like they didn't have time for their own kind of passions or interests. And through a conversation, mentioned something about Spain and that she just loves Spanish culture and wanted to find people to chat with Spain about. And so the connector found out about a small walking group that was meeting, and just happened that the walking group, all that they liked to talk about was Spain. And so she suggested that the caregiver start attending this really small community walking group. A few weeks later, met with the caregiver again and said that she was a completely different person. She loved going to this group, she made new connections, and really just felt that she had more of her time back once a week. And so I think that's really the value of this link worker role, and the value of this concept of social prescribing. It's really finding out what is meaningful to people and being able to take the time to connect them with those programs and services and grassroots different things that are happening in community that are kind of outside that traditional realm of healthcare. And that again is related back to those partnerships and that trust in the community and knowing what those things are that exist. So I'll leave it there, and I'm sure we'll be able to provide some more resources in the follow up that we're sending about social prescribing as well.
Yes, definitely. Thank you, Beth. And now, Daryl, I'm going to pass the baton to you. What does good partnership that supports caregiver, care partner thriving look like, feel like, and do? And can you share some examples in 5 minutes or less?
You bet. Thanks, Tanya. And I'm so glad I joined because I got to hear Beth's story about the impact that we made in a caregiver's life. So that was worth the price of admission all by itself. So I think, I think for starters, partnerships are going to rely on more conversations like this taking place. We know that we need to have the voice of the caregiver at the table. I think that was reflected in one of the chats. We've all heard that expression, nothing about us without us. So we need to have the lived experience here. We know from Dr. Wilson's research what caregivers have identified that they need. We have the lived experience here loud and clear from Debbie. So we need to find solutions to specific issues and challenges that are really moving the needle in terms of improving quality of life for caregivers in Alberta. And some examples that I can provide that really have made a difference in caregiver quality of life. One area is young caregivers, and that has been mentioned in the chat a couple of times. That is an underserved population in terms of support that is available to caregivers. So we partnered with Young Caregiver Association, secured funding from Calgary Foundation, and ran a pilot for young caregivers aged 12 to 15 in the Calgary area. We're running another pilot for youth aged 18 to 25 in June. So that is an example of identifying a problem, securing the resources, and then creating a solution. So that is one example. We know we're working on other partnerships, such as with community care agencies, such as Edmonton Meals on Wheels. They encounter caregivers through their drivers. So they sought a grant application. We supported that application so that they can provide meals to caregivers in the Edmonton area. We are, to Beth's point about social prescribing, I'll just add one little addition to that. We are partnering, working with healthcare professionals, doctors, physicians, to make them aware of social prescribing and the importance of recognizing the caregiver and making those referrals to Caregivers Alberta. We have a partnership, and I also want to acknowledge some of the good work that is already taking place. We are partners with many organizations around this call here tonight, such as Healthy Aging Alberta, Edmonton Seniors Coordinating Council, Alzheimer's Society, and Caregiver Centered Care. We're doing lots of good things together already. We also partner with individuals and communities to increase our capacity and leverage throughout the province. We need to connect with caregivers in rural Alberta. Caregiving is an isolating enough experience as it is if you live in a larger center. We need to connect with caregivers in small communities throughout the province. Through our partnership with Alzheimer's Society, we are looking at sharing our ambassadors. Each of us has an ambassador program. So our ambassadors can connect with us, connect us with caregivers in communities throughout the province, and that's a win for caregivers, for us, and for the Alzheimer's Society, and for the caregiver. So yeah, I think that I will end with. I'll mention one other little thing on the healthcare field, because we do a lot of partnerships with community care organizations. We have a partnership with Calgary West Primary Care Network. So we've created unique digital referral links so that their healthcare teams can directly refer people to us. We need to do that with every PCN. So that is a place where we are trying to connect with and create more partnerships. So I will end there. Thank you, Tanya.
Thank you, Daryl. And last but not least, I want to come back to you, Debbie. You shared your story and what would support you. What does good partnership that supports caregiver thriving look like, feel like, and do? What should it look like, feel like, and do?
I think partially, I think partnerships, I would look like more calls like this, more events like this, to bring people together and have this conversation and have this dialogue, to be able to support the capacity for people to connect and for caregivers to connect with each other and unite and have a unified voice, to be able to say, hey, we have some similarities and some commonalities. How can we create more better partnerships, and how can we create things that are going to work for us, particularly when we have an aging population and it's becoming more of an issue in terms of the sandwich generation. in I think partnerships with healthcare for healthcare providers to have some education and some level of compassion and understanding that when they give me tasks or task me with here, do these things for your granddaughter, okay, now do these things for your adult daughter about her diabetes, and do these things for your granddaughter for her medical care. Now here's the things that you need to do for your son, and here's the things that you need to do for your dad. And somewhat level of understanding that I'm one person and there's only one of me, and just having the compassion and understanding and knowledge to educate themselves about caregiving needs and about that really is helpful, and creates partnerships with so they feel supported, so that we feel supported. I think it's creating, like Beth said, those social prescribing things. I think that concept can be translated to people like me who support dependent adults, because I think I could see that working really well for dependent adults who are not supported by PDD, or who fall into the gap in service, who their RQ is 71 or between 71 and 80, where they do not qualify for PDD supports necessarily, but they still will struggle with day-to-day life without that level of support. So then it falls upon parents and their families to provide that support to them. Both of my children have fallen into this category, unfortunately, and that I think that social prescribing and that could be very useful and successful with this category of people. Things like I can tell you a little story about, we've been able to connect to create a partnership with the Seniors Lodge here in Fort Saskatchewan, is called Pioneer House. And my son really likes playing canasta. For some reason, I don't know why, he wants to play canasta, because it's something that he remembers from before he had his brain injury. And so they have a canasta club at the seniors center, and we've talked to them, I've had some discussions with them, and they're going to allow him to go there with his staff and play canasta. So we've been able to create that partnership at the grassroots level to be like, okay, he doesn't necessarily fit the criteria of your program because he's not 55 and over. However, he's in the community, and he's a community member who really has no peer support, peer group to speak of. And this would create some level of getting out of the house and some interaction for him. And he's really good with seniors. He's really good with his grandpa. And he likes to play crib, and he likes to play canasta. So they're going to allow him to do that. So creating those out of the box thinking partnerships really is another way to kind of do that. But I, kind of flailing around doing that on my own. And I think just partnerships even within our own family. I have created a system where my entire family has dinner at my house 4 times a week. So my adult daughter, my granddaughter, who we have sort of have 50-50 custody. So she goes between both households. My household, she has a bedroom here and she has a bedroom at her mom's. She's fluidly goes between, if her mom is struggling, she sleeps here. If her mom is doing well, she sleeps there. It's just sort of, but so like everybody eats dinner at my house, including my dad, which creates a partnership, creates that opportunity for me to connect with everybody, but reduces my level of stress so that I have everybody in one spot and I can go, okay, what can we do to support each other today? And then everybody we all play Uno as a family after. And it's just that good for our mental health and good for everybody to have that connectedness is really important for partnership. And I think connectedness for me has been primarily like support groups on Facebook for parents with children with disabilities, and for parents of adults with dependent adults, and just being able to connect with other parents or other people. And now I need to connect with other people who are supporting their adult parents who are struggling, but just connecting with others who have similar experiences and shared experiences, and not feeling so alone. If that makes sense.
Yes, it definitely does. And I think I'm hearing some common threads in this conversation here, that partnerships, I love your conclusion there, Debbie. It's that connectedness. right? It is really about connectedness. And I think I'm here at different levels. You need the connectedness in your life, but we need connectedness between our healthcare systems, our social care systems. And in the chat, I'm seeing it too, that we know that there are similar programs at different organizations. And I know that all the people here are working together to ensure that we are growing stronger together and we are fortifying what is there. And so I hear that, partnering starts in lived expertise that's embedded it comes from the caregivers, right? It's increasing recognition and supports within the realm of care. It's partnering to offer a variety of free, consistent supports to help with navigation and mental and physical supports throughout the journey at multiple levels across organizations through more conversations so we can do better together. And so I want to go around as a rapid fire here before we enter into our Q&A. And I'd like to hear from in our chat too. And I think I've already been seeing this in some of our chat is, the question, and I'm going to start with you, Tracy. The question I have is to support caregiver thriving. Wouldn't it be nice if?
Wouldn't it be nice if healthcare professionals understood the stressors that caregivers are under? And if we can hear from the caregivers about what they need for survival and then for thriving.
Thanks. And Arlene, to support caregiver thriving, wouldn't it be nice if?
If when you ask the question this evening, what it would take for them to thrive, that they could actually answer it because they had been able to take care of themselves, that they weren't exhausted, that they had all the respite at the right time, and that they feel they're living well.
Thanks, Arlene. Beth, wouldn't it be nice if?
Healthcare system was open to new ways of doing things.
Daryl, wouldn't it be nice if?
Yeah, it would be nice if we were all aware of the role of caregivers in our communities and how to support them. And we knew who among our neighbors were caregivers and what life is like for them. It's a bit of a different twist. Not everything has to be at the level of systems and institutions. It could be at the level of community and individuals. And we can do that through culture change, through storytelling. An interesting thing came across my desk today. Bradley Cooper is making a documentary on caregiving that will be on PBS, I think. So, yeah, you can put that in your back pocket.
Thanks, Daryl. And Debbie, wouldn't it be nice if?
Wouldn't it be nice if partnerships and caregiver thriving was actually attainable?
Mm-hmm. Oh. And so I want to thank our panelists. I'm going to be coming back to you, so don't go anywhere. Donna, we're going to welcome you back to our screen because, and actually, Donna, as you come back, I'd like to put the question to you too. Wouldn't it be nice if?
Oh, I'd love to answer that. We all know AHS is being broken up into 4 groups. Wouldn't it be absolutely amazing if there was more money put into home care and community supports and a group that looked long-range planning for population aging and, to help disabled children and caregivers and everything else. Yeah. So wouldn't it be great if that break of a AHS meant that we have one group that really is looking for services around the province and long-range planning and more money. So the money doesn't always get siphoned into hospitals and emergency departments. Woo, that's my wish.
Thank you, Donna. And I don't think the Q&A, I'm not sure if there has been any. Oh, there is one Q&A, and I know that there are some questions that are in the chat. So I'm going to do my best because of the lively chat to find all those questions. And if I miss them, I will reach out to the speakers today and I will get the answers via email or in some form so that we can get them to you in the digital swag bag. And so I'll start with the question that is in the Q&A. And so we have, I appreciate the work being done to take care of caregivers. However, how do we as caregivers relax and enjoy our respite time if we cannot trust the home care aides with taking care of our loved ones. So can I put that on you? Tracy, you're coming from healthcare, so I'm gonna pass it to you, and others can chime in. I can, I'm a healthcare provider as well as with caregiver centered care, as well as a caregiver myself. And so I think we've got work to do to continue to ensure that the care provided is caregiver centered, and so that you can have that trusting partnership relationship. Tracy, I'll hand it to you.
Well, I hate to say that my answer is, if you don't trust the people who are in your home with your loved one, you're not going to take your respite care. You're certainly not going to enjoy it. You'll spend your entire time away worried, and it's more exhausting than actually not taking the respite care in the first place. To fix whether or not you can trust the person with your loved one, and this is, I think, one of those catch-22s, is you need to have been able to develop that trusting relationship with somebody who's coming into your home. But if that is a constant revolving door, a new person every week, then how do you develop that? I don't have an answer for that, other than the fact that it just has to be that constant open communication. If you're not feeling comfortable with the person, it doesn't have to have a good reason or a legitimate reason. If you just got a gut feeling and you're not happy, then you have to be able to say something. And then when you say something, we have to listen to you. And that, I think, is where the big disconnect is from what I'm hearing, is that a lot of you are just like banging your heads against the wall, saying the same thing over and over again, and are probably not enjoying any of us saying, you just have to communicate and let us know what you're thinking, because you've been trying that. So I think it comes from caregivers. I don't know if there's such a thing as a local action committee for caregivers, but there kind of needs to be one, because you have a lot that you're doing for the society that's not being valued. And once something's not valued or even seen, there's not a lot of effort put into fixing the problems with it. So I would say, as much as it may not be what you want to hear, the more you keep telling us. If you're having troubles with people, you have to tell us what's going on. And I wish I had a better answer.
And Daryl and Arlene, you have programs for caregivers, and so I'm sure you've heard these stories. And so I'm wondering, do you have anything to offer to guide us forward? Because I don't know if we have an answer right now, but I think it tells us there's a way forward here.
Yeah, I would throw out, and Jill, you can always give us a call, as you know us very well. But I would say that when you talk to the organization that's going to be providing your home care, your respite, that you ask them to share your file with the person who will be coming out. We see this as a big gap in home care as well, that it's the case manager who comes out and talks to Debbie or to Jill, and then they don't see them again for a long time. But these other individuals come out and they don't know that, Debbie's dad, I think it was Debbie, likes to play canasta. They don't know that someone likes to go for a walk. So to be able to read that first report, I think would build trust. Because if I could walk in and start talking to Jill about, oh, I saw your husband likes this, and I know you like to go paint and blah, blah, blah. I think that starts the building the trust. But when a person comes in and they don't even know which person they're there to see, I think that's part of the lack. So I would ask the company providing the care, the respite care, that your thing is shared. Often they won't do that. So also I would encourage everyone to have a write-up about your family member and write up about what you're looking for, so that, again, when we talk about partnership, that you've done your part to say, this is who we are. Now tell us some about you, and we can, at least you start at a basis, and hopefully what your goals are. I would like my husband to get out. I would like him to be able to walk. I don't want him to walk. So a bit of that sharing would help. And Jill, I know you've probably done all that, but for anybody else that might help. Daryl, over to you.
Sure. Well, this may be an example of where a solution is required at the level of systems. When we were up in Fort McMurray, and I see Guy in the chat with several really good comments, and had the privilege of meeting Guy while we were up there. And somebody had raised the question of, When I am able to access funds through self-managed care to care for my care recipient, I have to use those to hire somebody to come into my house, my home. I can't use those funds to hire a family member. And we know that caregivers are often under financial stress. So why can't we change that, right? We know, now don't quote me on this. This is what I have heard, that in the children's ministry, you can use funding to pay a family member to care for your child. Why can we not do that for adults caring for a care recipient? And that would also ease the burden on the paid labor force as well. So that is a systems level advocacy piece that I think we can address.
Thanks, Daryl. I'm going to go down to my next questions here. This one, I think, Beth, is for you. And I'm not sure if you answered in the chat, but I also want to put it on the recording too, it was asked, how do I connect my 80-year-old neighbor to Link?
So our social prescribing programs, right now, we're trying to intentionally make that connection with healthcare providers. And so ideally the referral would come from a healthcare provider. So whether that be home care, family doctors, pharmacists, like we're kind of attacking it from all angles. So I did share a link in the chat to the program in Edmonton. And hopefully you're able to get connected that way.
Thank you, Beth. And another question that it was also answered in the chat, but I just want to put it out on the recording, is caregiving concept and supports in medical training? And I can say that's an area that our group and team is working on with our caregiver-centered care. It is beginning to be embedded into various health care providers, student training. We are co-designing physician education as well as we speak. And so that is our hope. It is happening, it is coming. And so we hope that it continues to spread. Another question we have is how much and this is for you, Tracy, I believe, how much are the frontline nursing care staff involved in the review of an incident? And are their ideas considered alongside of family caregivers?
Yes. So there are a few different ways that we review something. The vast majority of adverse events are reviewed at the unit level with the staff who are involved as soon as possible after the event has occurred. The goal of every single review is going to be that we learn something from it, that we can proactively put into place. So patient safety is always reactive and proactive at the same time. We're reacting to something that's happened, but we want to proactively put into place changes so that it won't happen again. The vast majority of adverse events are dealt with through quality improvement, through quality councils at the unit level, including the frontline people. And it's the staff who know what's really happening. So when we have the vast majority of those reports being done at quality councils, those quality councils have caregivers, partners on those meetings. When it comes to a larger review, we have stakeholder analysis teams, and we always ensure that it's easy to make sure we have the leadership of the levels, but then we always make sure we have a frontline person who is going to represent what is actually happening, because it's one thing for us to create all sorts of new policies and procedures that are just not tenable for the real world. And we are just starting, we've had one formal review that has had a caregiver partner on board with us, and it has given everybody a new view of how to review these adverse events. Every single adverse event that ever happens within healthcare deserves and requires a review. It's just that most of them are not called a formal review, but I would say the vast majority of them are with frontline caregivers. And when I say caregivers, I mean our staff and with the partners that we have.
Thanks, Tracy. Another question in our Q&A, something that I really appreciate in Ontario is Home and Community Care Support Services, HSSCC, formerly LHIN. They do assessments of people and can help connect people with some supports. For example, they assessed my father to receive 30 minutes per day of PSW support funded by Ontario Health Insurance Program when my mother passed away and he could no longer live on his own. Is there a similar type of organization in Alberta? I'm going to put it to anyone in the panel. Are you aware of organizations in Alberta that offer this sort of service. I will say that with the passing of the Continuing Care Act, I think that is the idea that this does get better, that caregiver needs are assessed and are addressed throughout the journey of continuing care, which includes home care as well. And so can anyone else offer any insights?
If I can jump in, typically after you've applied for continuing care services or home care or whatever, you would be, if you were accepted into it, after you were assessed, you would be assigned a case manager who typically was a registered nurse. Unfortunately, though, a lot of those have been laid off in recent months. And so we've got a gap in the system right now. And it's a big problem because there was the case manager would say, oh, here's where you go for that. Okay, I'll help you apply for this. I'll get you the application form. Oh, you should be able to get this and get that. These tended to be people that were really aware of what's available in the community. So at this point, really, if you've got maybe an organization in your community, like a seniors group or a church group that, those are having to take the position of, a paid registered nurse who is acting as a case manager. So we've got a gap in the system. And again, the money was funded, siphoned back and put into the hospitals and emergency departments. And so I'm hoping all of you are telling your MLAs and, what have you, that this new continuing care system, this organization should be doing this and this and this and this. Like we need case managers, we need link people, we need, this is what we need in the system. And we want more money for home care and all the rest of it. So this is a time when when family caregivers need to really speak up and organize. Good organizations, great people like all of you need to really engage with government and tell them this is what we really want. We need it.
Thanks, Donna. I see Arlene, you raised your hand.
Yeah, I just wanted to add on, and I think we need to do a shout out to Dr. Jasneet Parmar. A few years ago, she worked super hard within home care, that home care would not only provide services, say, to the person who is ill or needing that support, but that caregivers, care partners could also become a client within home care as well. I encourage all of our care partners to ask for that. I know some have said that their case manager has never heard of such a thing, but I continue to fight Jasneet's fight that she began a long time ago. So as Donna said, the more pushing back we do, the more asking we do, it will come. So, but other than that, it really is home care who would provide those services.
Yeah.
And Debbie, I'm going to hand it to you because I accidentally cut you off. I saw you unmute and then started talking too soon. Sorry, Debbie,
No worries.
to you.
I just wanted to speak to this because when I got approved for self-managed care for home care for my son, before we had self-managed care contract and we were just getting home care services, we got a social work referral because I come from a social work background. I'm all about like, do you have a social worker? And they said, sure, you want to see her? I was like, yes. They didn't have a social worker in our area, in our region, because they were hiring, and so because they of a mat leave or whatever, so they pulled a social worker from another jurisdiction to come and do some social work for us. And the case management and the resources, and she was able to pull resources and do some of that case management piece for us. You can ask for, if you qualify for home care services through in Alberta, you can ask for a social work referral and receive some case management services through that social work referral, and get connected through to resources and access services through social work through that program. You have to ask for it and advocate for it, though, because they won't just give it to you.
Yeah, thank you so much, Debbie. And we have about 3 more minutes for our Q&A before we get to the closing. And so thank you for my chat moderators for summarizing some questions that I have missed along the way. So unfortunately, we only have 1 more. And so I am, okay, I like to finish with this one. I'm so overloaded as a caregiver that I can't gather and organize and contact my MLA. Who can help me? And I think our whole panel, I'm just going to quickly go around. What is your commitment to help? Debbie, you're already doing so much. I'm not going to say you need to check out something else, but I want to go around to our organizations who are with us. What is your commitment to help? Because you're here and you're dedicated to really support this change and partnership. So Tracy.
Right at this moment, I'm not sure. I'm not like a minion at work here, so I have no idea what the higher ups are doing. But I've been keeping notes here, some of the suggestions in the box of some very basic things that we could do to help that I'm surprised to find out we don't have. So I think that it will be something that I bring forward to our patient relations and engagement department to say, what can we do? Like, can some of our organizations like Bella Caritas, can they start and help with a support group? Because that's what a lot of you are saying, that you need somebody to be able to just chat with, virtually, in person, whatever your situations allow for. What can we do? I think that I can't give you an absolute of what we can do to help right now, other than the fact that keep notes, keep hearing you, and see what we can do and how we can advocate as an organization to the government to say, this is what is needed. Because I will echo Arlene, and I'm from acute care, and we have a lot of problems, but we don't need to siphon money out of other areas to make those problems look better. That doesn't help in any way. You can take the money from one place and put it in that merge. It sounds good to the public at the one time, but that's not helping, because you're taking the money away from people who give them the right amount of funding. They won't come to merge in the first place. So we have as an organization to advocate to the government on a regular basis, not just during special months, but on an everyday kind of basis, to say, this is where we need help. This is where the people need help.
And I think too, I'm hearing like really change our sphere of influence, change our organizations where we can to
Yeah.
make this journey a lot easier. Arlene and then Beth.
Yeah, our organization, through our CEO, meets with government people all the time. And so doing advocacy work at that level, as well as our board with our strategic plans. So I would say our organization is always trying to do it at a more kind of grassroots level. If you're one of our family members that we serve, we've helped family members kind of write a letter, read a letter, tweak a letter. Sometimes they've got it ready, they just don't know how to find who their MLA or their MP is. So, some of those kind of what I call lighter jobs we can do. Obviously, we couldn't do that for every one of our clients, but not everyone needs that kind of support. So I would say our organization does that. I would just have to say, I wouldn't encourage medical organizations to start running care partner support groups. I find that has failed in the past. So I'd leave it with the community.
Thanks, Arlene. Beth.
Yeah, I think our organization is really fortunate to have good relationships within government. And one of our roles in the sector is to kind of advocate for needs from what we're hearing from communities on the ground. So we have 5 different regional community developers that work in all different areas of the province, and they're on the ground. They're listening to what the needs are in terms of supporting older adults specifically. That's kind of our mandate. And so one really good example of that is that we recently have been able to kind of support, I think, up to 25 different rural transportation programs across the province, because rural transportation was the most common thing that these regional community developers were hearing on the ground. So it's I think a $4.5 million investment right now, but hopefully will continue to grow. And again, now we're on to the next thing. And I think respite care is one of those things that we're hearing across the province is such a big issue. And so that'll be something that our Community Leadership Council keeps advocating to different levels of government, different partners for. And hopefully in the next few years, we'll be able to see more investments coming into that, to those community-based programs. So you got to find lots of different avenues to kind of advocate through, and trust that there's people that work within these organizations that are hearing you, that are here today and have heard all of your voices, that continue to push those buttons and speak to the needs of caregivers and others in community.
Thanks, Beth. Daryl, we don't have much time, but can you answer this question in 20 seconds or less? And I just want to say we're creating a chat poem too. So I put something in the chat for you all to see that I'd like you to finish the sentence that I placed there. It's gone up a little bit, but the journey of partnering a path towards caregiver, care partner thriving. Type it into the chat, but don't press enter until I say go. But Daryl, what is your response to this question?
Sure. Well, we heard one of Debbie's needs is mental health support, right? So we know that more people connecting with us need mental health support. So we are looking to partner and find money to make that happen. We are looking to continue this conversation and do a deep dive into respite in the fall and bring people together for that. And I'll do a little plug for our conference in November. We are looking to build community support to figure out how we can support caregivers throughout the province and bring in speakers and workshop ideas to create wraparound support in the province.
Awesome. Thank you, Daryl. And we're in our last minute. And so I just want to thank you all for coming. Stephanie had posted a link to our survey. You will be getting it in an email as well. Please evaluate. Please help us continue to improve and hear your thoughts and perspectives as we do partner a path forward. And now I'll ask you, those of you who were typing an end to my sentence, if you can all press enter, submit, go. And continue to do that. What I'm going to do is I'm actually going to create a collaborative poem that we're going to put in our digital swag bag. And so we're going to, I'll probably grab from the rest of the chat comments too that were said today. And I just want to say thank you so much. We have a long journey ahead. We know we do. We know there's a lot of holes and gaps, and we know that we're all weaving together to fill in those holes. So hopefully in the future, caregiver thriving is a possibility, because it's becoming clear that right now in this time is not, but we are all trying through our spheres and our networks to grow. And that's why I'm really looking forward to this Alberta strategy to bring all this great momentum together with some focused funding, because all of you all are partner collaborators in that endeavor. So thank you. It's 8:30. I probably took us a few seconds over, and again, I'm in awe and honored.